the images.
Okay, thanks, Enrico. So I'm going to go ahead and get started on this first topic in this course. These are my relevant disclosures. And so I can't underscore how important acquisition is in regards to being able to do good OCT interpretation. And so this is kind of the usual, the garbage in, garbage out kind of cartoon. Ultimately, your ability to interpret your OCT is obviously going to be impacted by the quality of the data that you collect. Oops, going in the wrong direction here. Okay, I'll just try using this then. So there are a number of different considerations that are relevant to OCT acquisition and viewing, and I'm going to try to tackle these quite rapidly, but cover some of the key areas. Let me start first with OCT instrumentation and scan positioning. We have a lot of choices. I guess this is a good thing for us as ophthalmologists and as consumers, that there's a lot of competition, many devices that are out there, both in terms of spectral domain and swept source devices. And these devices vary in terms of their scanning speed, the wavelength, resolution, and also the accessory imaging modalities that they can possess. One of the key differentiators, of course, is whether the device is swept source or spectral domain. Swept source technology does have some advantages with regards to its longer wavelength and deeper penetration with the higher speeds, and also this important advantage of less sensitivity roll-off. And I think most of us are familiar with this concept, but it's been a while because the OCT has been around, so perhaps we've forgotten that that OCT, of course, this technology, all of these Fourier domain technologies are subject to loss of signal with depth, and this is sort of seen as you depart from what we call the zero delay line. The signal gets increasingly noisy, and it's harder to resolve the structures. This is pretty much typical of a spectral domain OCT. And it's important to recognize that one advantage of swept source is that the drop-off in sensitivity with depth may not be as steep. It doesn't mean that there isn't a drop-off, it's just not as steep. And that provides some advantage if you're trying to image deeper structures such as the choroid, shown in this illustration. And so that's why if you want to assess the choroid, obviously swept source OCT has some advantages. You can even use spectral domain and use a longer laser wavelength, but we don't really have commercial devices that offer this. But the strategy that, of course, is available to us is to do enhanced depth imaging, where we orient the point of maximum sensitivity towards the choroidal side as opposed to the vitreous side, and that allows us to maximize the viewing of the choroid. The reason I highlight that here is that if you're planning on studying the choroid or interested in pathology involving the choroid, you need to collect this type of data. If you don't obtain it, then you're not going to be able to do this assessment very well. Let's move next to scan dimensions, because this was not really much of a choice in the past, but now with newer OCT devices, the field of view has steadily increased, and we have devices that can give us 23 millimeter scans. And some of you might say, well, okay, are such scans actually valuable? And I think certainly there are pathologies that can involve extensive regions of the retina, where having very wide scans can be of value, like in this patient who has very extensive schisis related to a pit retinopathy, or sometimes to perceive the topographical changes in contour for certain diseases like dome-shaped maculopathy. It's nice to have these very big scans, and so it's useful, I think, to acquire these to better understand the disease. And of course, now we have the ability to do peripheral OCT, which is very useful for evaluating pathology closer to the ora serrata. Also, having wide OCT can help us with certain diseases like pachychoroid spectrum disorders or choroidal vascular congestion disorders, where it's very easy on FOSS imaging to appreciate the choroidal vascular congestion. And of course, with montage wide-field OCT, you can go even further and actually start to visualize the ampular region, which may be the region that's most involved or impacted and relevant to the pathophysiology of these conditions. Now, you can use this kind of a wide field approach of OCT imaging to OCT angiography as well. And our devices now, whether through montage or even single huge acquisitions, can give us quite extensive field of view, which can certainly be valuable for assessing various retinal vascular diseases. The challenge, of course, is that some of the devices that can do this can be quite expensive, and it can also be time-consuming. If you're going to do montages, which we sometimes do for diabetic patients, that can take quite a bit of time. And so are there alternatives? One approach, this is something that one of my former fellows, Akihito Uji, had come up with, was just simply using a 20 diopter lens with a standard OCT to extend the field of imaging which you can do quite simply. That can be applied to OCT angiography as well, as we demonstrated, and this can considerably increase the field of view. So this is a way of trying to get a greater field of view compared to your standard 12 by 12 acquisition in this case, without having to take the extra time to montage. So something to consider in certain applications. Of course, nothing comes for free. If you're going to do that, you're going to lose resolution. Obviously, one of the disadvantages of going wider field in general is less resolution. So you have to think about, well, for my particular application, is that okay? And really, that's really one important message is you need to choose your protocol based on your desired application. For wide field imaging, if you're looking at peripheral non-perfusion, neovascularization in the periphery, probably a low resolution is okay. But if you're trying to do fine macular work, evaluate the choroid capillaris, study macular neovascularization, you will need smaller scan patterns. There are a whole host of different scan patterns one can choose. I will say in our practice, we choose 6 by 6 kind of as a default, as a compromise, because sometimes we want to go back and look at this data. We don't know. And if you're going to do research or studies later, it's nice to have a consistent protocol. Let me say a couple of words about B-scan averaging. It's well established that averaging B-scans can reduce the speckle noise, but how many B-scans do you need to average to actually get good scan quality? Well, it really depends on the device. I mean, for example, with the Cirrus OCT we previously published, that you didn't really see a huge jump after you went to about 4x averaging. Going beyond that didn't really seem to make a difference. Others have more recently studied this for other devices like the Spectralis and found that 16x may be the optimal averaging level. But the reality is that you have to balance this, right? If you do more averaging, maybe you can't do as dense a volume, and that might limit your ability to do on-FOSS imaging and the like. So I think you have to tune this. We tend to use as a default in our practice 9 times averaging, but again, you have to adjust this based on various factors, including even the patient cooperation. Averaging also is beneficial for OCT angiography. It's really not practical to do 9 OCT acquisitions, but you can do a couple. We used to do this pretty consistently. Now we have artificial intelligence-based techniques to simulate the impact of averaging, so that may be an alternative to rather than take the time to actually do the averaging. Just a word of caution about segmentation errors. Long ago, this is back in the time domain OCT era, we'd highlighted that the machine segmentation could often be erroneous. This improved a bit with spectral domain OCT because there's an advantage of having adjacent B scans that actually improve the performance of these segmentation approaches. And obviously with AI, we're doing better and better, so maybe this is less of an issue. But I just want to highlight that when there are segmentation errors, they're not always obvious if you just study the retinal thickness map. Many practices, they don't want to take the time to look at all of their B scans. If you just look at the map, you may sometimes miss what's actually happening. Like in this illustration, where this patient didn't actually improve. It looked like the map was much better, but it was just because there was different segmentation. In one case, the PED was included. In the other case, after treatment, the PED wasn't. So it wasn't actually a treatment benefit. So you need to look at your B scans, and so how many do you actually need to look at and acquire? We've studied this systematically. We did an initial study where we looked at patients who were undergoing anti-VEGF therapy for neovascular AMD, and we looked for the presence of fluid by looking at every B scan within 128 B scan volume. And then we said, what if you just looked at the map and you were looking to see was there new fluid that appeared by just looking at the map? We found that this was not very sensitive for detecting the presence of new fluid. Now, if you looked at a few B scans, your sensitivity improved, but how many B scans do you actually need to review or need to obtain? And so we did another study where we started with 128 B scans, we looked for the presence of fluid, and then we essentially started to take out half the scans. And then we asked the graders to assess, well, is there fluid present or not? And did the same thing after removing another half of the scans, and so on and so forth. And basically, we observed that if you drop to below 64 B scans in this case, you started to lose sensitivity for detecting fluid. So again, did that make a difference in terms of patient outcome? That kind of information we don't know, but that's something to consider. So that's why we like to do dense scanning. We also like to do dense scanning so we can do on-FOSS viewing. I like to say at least 98 B scans over 6 millimeters. The good news is in this OCT era, we have to get dense scans anyways, because I really believe you should be doing isotropic scanning, but at the very least, do dense scanning that allows you to do on-FOSS visualization. So to summarize, I think acquisition strategies, thinking about them is quite important in order to collect your data appropriately for both clinical practice and clinical research. Especially if you're planning on doing retrospective research, you'll really regret it if you didn't think about the protocols that your practice is using, and even consider doing these additional acquisitions like EDI and the like to make sure that you are getting the data that you need for future use. Thanks very much.
Thank you. So there is any question from the audience? I have a question. So in terms of clinical practice, do you suggest to make a single scan, 2 scans for each patient in order to even reduce the number of issues? Which is the best approach in our clinical practice?
For OCT angiography or just for OCT?
Just for OCT.
Yeah, I think that I don't think there's a need to do another acquisition. I think you can do a single dense volume is sufficient with a modest amount of averaging is sufficient for most of our purposes. Really, you need to train your, one thing I didn't mention is training your photographer or whoever is doing the acquisition if the quality of the image isn't going to repeat them. So I don't think you need to necessarily obtain multiple. It's more a matter of actually spending time to train the person acquiring the images that if they didn't get good images to repeat them then, because it's always such a regret, right, when you're trying to do a study and you can't go back, you can't get it, so.
I completely agree with Dr. Sadda on the importance of imaging protocol, because when you do retrospective research, you will regret, actually, if you didn't do the correct scan. The problem is try to find like a balance between your clinical activity and your research activity, because, for example, my resident hate me because I do very, very detailed protocol exam for surgical patients, for example, for ERMs, macular hole, and so on. And this can be slow. Okay, this can slow down your clinic. So it's a matter of finding a balance between the flow of your clinic and what data you want to use from your patient. It's not easy. It's very hard actually to find the balance. So yeah, but it's important to have like an imaging protocol. Very, very important.
Okay, so if no other questions, then we'll move on to our next presenter. So I'm pleased to introduce my co-chair, Enrico Borelli, and his talk is entitled A Basic Approach to the Initial Review.
So we're going to see the basic approach for OCT images. And in particular, when we perform a structural CT to our patient, it is always important to see the different parts of the retina. We should start by assessing the vitreomacular interface. Andrea is going to get details on this, but we must remind that different disorders may affect the vitreomacular interface, and so this should be the first step in our OCT assessment. So once we have seen the vitreomacular interface, we may start to look at the neuroretina. The neuroretina may be affected by different disorders, and in particular, using structural CT, we may appreciate the presence of intraretinal or subretinal fluid. The presence of intraretinal subretinal fluid may be associated with different disorders that may be categorized in these different groups, and for sure the exudative form is one of the most common. Even within the exudative form we have different disorders, but for sure AMD and diabetic retinopathy are two of the most common disorders associated with the presence of intraretinal and subretinal fluid. So once we have of course, a case of diabetic retinopathy and intraretinal and subretinal fluid, we must employ a multimodal imaging approach, but using structural OCT, you may also appreciate other characteristics which are actually associated with the worse visual acuity. So if you have a patient with DME, you may want to use a structural OCT even to detect the presence of a disorganization of the retinal inner layers or a disruption of the outer retinal layers. And even in AMD, regardless of the presence of intraretinal and subretinal fluid, it is always important to look for other OCT biomarkers associated with a worse visual acuity, as an example, the thickness and the presence of the subretinal hyperreflective material, but also the presence and the size of the macular atrophy. So let's go back to the causes of intraretinal and subretinal fluid. There are also other causes. This is a clinical case. This is a patient with drusen. We perform structural OCT. You may appreciate the presence of subretinal fluid. So we wanted to understand if there is any new vascularization. We perform both OCTA and ICG, which actually didn't show any new vascularization. So this is a case of non-new vascular AMD with subretinal fluid, which was described by Dr. Saraf and other co-authors. So when you have a case of subretinal fluid, please remind that this may also be a case without new vascularization, so we don't need any treatment in this case. After the presence of intraretinal subretinal fluid, we must look for the presence of subretinal hyperreflective material. It is important to employ a multimodal imaging assessment to better understand which lesion is associated with this OCT finding. The presence of this subretinal material may be associated with hemorrhage, type 2 macular neovascularization, and other types of lesions. So it is important to employ multimodal imaging assessment, and this is a case with this is a patient with myopia and this subretinal hyperreflective material. So we perform this is a multicolor image which show the presence of an hemorrhage, but we also perform OCTA, which actually show the absence of a new vascularization. This is a tricky case, as sometimes we have hemorrhage and subretinal hyperreflective material, and this may be associated, the hemorrhage may be associated or not with the new vascularization. So in this case, there was no new vascularization. We decided to follow up the patient, and there was a complete resolution of the subretinal hyperreflective material. So let's go back to our assessment. After the neuroretina, it is important also to look at the RP. The RP may be characterized by atrophy, of course. RP atrophy may be associated with different disorders. Regardless of the disorder associated with RP atrophy, this is characterized by a signal hypertransmission, an attenuation or disruption of the RP, and evidence of overlying photoreceptor degeneration. These are the OCT signs associated with RP atrophy, again, regardless of the disorders behind this kind of OCT features. In AMD is, of course, one of the leading causes associated with RP atrophy, and in these two studies, there was a clarification about the terminology we should use. There is a difference between iRORA and CRORA. The main difference is the size, but please remind that most cases of iRORA, so of incomplete RP and outer retinal atrophy, may progress to CRORA within 2 years of follow-up. And finally, if you have a case of RP atrophy, you may also want to select a slab right below Bruch's membrane, which highlights the presence of hypertransmission. As you can see in this ANFAS image in this slide, it is quite easy to detect and to track the progression of the RP atrophy over time. So this is another chance we have to improve our ability to investigate and to follow up patients with RP atrophy. RP may be also detached, and this is another characteristic we may appreciate using a structural OCT. We have different types of RP detachment. For sure, one of the most important is the fibrovascular PD, as in the presence of a fibrovascular PD, we may want to treat these patients in the presence also, of course, of signs of exudation. And a fibrovascular PD is an OCT sign associated with the presence of a type 1 macular neovascularization. So when we suspect a fibrovascular PD, we may appreciate the presence of a double layer sign, a thick double layer sign. A thick double layer sign is characterized by the presence of some hyperreflective material between Bruch's membrane and the RP, this must not be confused with the thin double layer sign, which is usually associated with the presence of basal laminal deposits. So in the presence of a thick double layer sign, this is a good sign on structural OCT. There is a good sensitivity and specificity, and it is usually associated with a type 1 macular neovascularization. When we see a thick double layer sign in patients with central serous chorioretinopathy, there is no that good association with the presence of a new vascularization. So a thick double layer sign is a good OCT sign associated with the type 1 macular neovascularization in AMD, but this is different in CSC. The sensitivity and the specificity of this OCT sign is lower in patients with central serous chorioretinopathy. As you can see, this is a patient with a double layer sign and without no new vascularization, as we can see on both ICG and OCTA. And this was the specificity and the sensitivity of this OCT sign in central serous chorioretinopathy, which is lower than AMD. So let's go back to our assessment. Finally, we should look at the choroid. Of course, there are different characteristics we may appreciate using structural OCT, but the thickness of the choroid is something important, as this is associated with different disorders. So in conclusion, using structural OCT, we may appreciate different biomarkers and different characteristics which are associated with also with a number of disorders. Of course, it is important to have a step-by-step approach to OCT images, but OCT should be integrated in a multimodal imaging approach, as in several disorders, the OCT sign may be associated with different findings. Thank you so much.
Thanks very much, Enrico. Very nice presentation. Any questions from the audience? Yes, please come to the mic. Can we turn the mic on, please? Yeah, it's on.
Is it on?
It's on.
Hi, this is Pamal Ashwin from the United Kingdom. Thanks for a nice talk about biomarkers. My question was about intraretinal cysts. And why is that terminology not being used very often? Has it become obsolete, or has it become merged with intraretinal fluid? Because we used to use the term intraretinal cysts for chronic cystic spaces, where no matter what you do, those spaces remain, and not to confuse them with the presence of intraretinal fluid. So that was one question. There is another terminology called SIRE, shallow irregular retinal elevation. Is it synonymous with your double layer sign or flat irregular pigment epithelial detachment? And a final comment really is, when there is so much confusion about biomarkers, is there something being done internationally to standardize these terminology and definitions so that there is consistent use across the globe? Thank you.
So thanks for your comment. I will say that standardization is one of the most important aspects in when we see OCT and OCTA images. Regarding the other two questions, the flat PD may be characterized by the presence of hyperreflective material, and this double layer sign may be a thin double layer sign or a thick double layer sign, but in both cases there is a flat PD. And finally, the intraretinal cyst is for sure an important terminology, and may be associated with exudation, but also with other causes. So this is something I will need to highlight more in the next presentation. Thank you.
So I would just, can I make one comment about the, from being a semantic stickler, really it's not a cyst obviously, but we like the term cystoid space. But it's still used, but I guess people have recognized that intraretinal fluid can be in cystoid spaces, or there can be more diffuse thickening of the retina where you don't see discrete cystoid spaces. So sometimes people use the overarching term intraretinal fluid to be suggestive of both. But I don't think that it's fallen out of favor Yeah. Okay, so we will move on to our next presenter then, and I'm very pleased to introduce Rosa Dolce-Marco, and Rosa is going to continue.
Because the key thing here is that OCT is not the retina, right? The retina is that you see on the right, is not the OCT. So when you see an OCT, you need to have in mind histology. And this is what I always tell to my residents, at least to those few that listen to me. But I mean, you need to know histology. And this is what I've learned from the medical retina guys. So they are so good because they know exactly which cells are in each layer of the retina, and they know where they are on the OCT. So we surgeons normally don't do that. We just operate and do things, and that's it. But I mean, you need to have a deeper knowledge of things to improve your surgical result and improve the follow-up of your patients. So let's see what we did in surgical retina and how to interpret those images. So first thing, we need to know, I mean, Rosa already told you the anatomy, but the important thing is that knowing the anatomy of the Mueller cell is very different from the center of the retina than to the parafovea and the periphery. So in the center of the fovea, the Mueller cell, we know they are straight. In the parafovea, they are Z-shaped. In the periphery, they are straight again. So this means that the pathology of the periphery and the fovea can be very similar because mechanical forces are transmitted somehow in the same way. They are very efficiently transferred in the center, in the periphery, and very poorly transferred in the parafovea. And this is why you never see, almost never, parafoveal macular hole, for examples. So this is a study that we did that you will see on retina soon. And let me show you the anatomy also of the vitreous. The vitreous is very difficult to see with OCT because it's transparent. You cannot see a transparent mean. It's very difficult to image it. So you know that the fibers of the vitreous are like parallelly oriented, like in the center and in the mid-periphery, but they are very vertical oriented, perpendicular to the retina in the very far periphery. You can see it with OCT. You see this line are the vitreous fibers, and these lines are the vitreous fibers. And this is why you have like breaks in the periphery. So with OCT, you can also see vitreoschisis. Vitreoschisis is something that we saw in the posterior pole, but we were never able to image in the periphery. But with current OCTs that can go also wide field, you can see that the vitreous splits here and creates the break. And this means that there is not axial traction, but there is like tangential traction, horizontal traction that is creating those breaks. It's something that you can get to by interpreting OCT images. So you can see vitreoschisis here. With OCT, you can do this nice reconstruction of the break, and you can navigate through them. We don't know exactly the clinical application of this, but there is something that the OCT can tell me about the morphology of this break. So for example, horseshoe tears, we all know them, but they are different. The morphology is different. You see some of them are more flat, some of them are elevated, some of them are rolled. So when they are elevated means that the vitreous traction is exclusively on the anterior border. When they are flat, the vitreous is all around, so means that there is traction everywhere. And this is important when you go there with your cutter. When they start to be rolled, means that there may be some PVR stretching there. And this is, you can see in lattice degeneration, you look at how beautiful you can image the vitreous here. This is like cells, and look here, the photoreceptor detached from the retina. These are all beautiful things that we now start to see with OCT even in the periphery. So this is the most interesting thing that we discovered, that actually the atrophic hole that we all call atrophic, they are not actually atrophic because there is traction there, tangential traction due to vitreoschisis. In all around atrophic holes that we found in the periphery, there was traction. That means that maybe, and you can see that the vitreous is like pulling the retina tangentially, and that means that maybe they are not atrophic, but they are due to traction. So traction is at the base of photorhematogenous pathology. And look at here how beautifully similar is this vitreoretinal traction in the periphery and how is like the same in the macula. Means that the pathology is somehow shared between the two locations. So at the end, traction is important in vitreoretinal pathology in all of like the rhematogenous lesions. Good. So by knowing that in the center of the fovea there should not be in the retina, and we know this due to histology and development, you should notice that in this membrane there is something weird, but because there is inner retina in the very center of the fovea. So by knowing this, we investigated when I was like at UCLA a while ago, we started investigating with Dr. Saraf as well, and we found that this tissue is not normal. This tissue, we call it ectopic inner foveal layers. It means that the traction of the membrane is bringing over the fovea inner retinal tissue. And we use this to create this staging system of ERM that is now widely used around the globe and is like clinically relevant because you know that when this tissue forms over the fovea, the visual acuity goes down and the surgical results are also worse. So your interpretation of your CT is very important to improve your clinical practice. And you see how the FIZ is like basically obliterated by the vessel because they are like pulling centripetally. And knowing that the vessels are different, like you can see, you can differentiate between people with congenital fovea plana, for example, where you see these foveal capillaries throughout the fovea, from like an epiretinal membrane, where in the fellow eye, if there is no membrane, the vessels are completely normal. So again, knowing histology and knowing the anatomy is very important. So this layer basically acts as a shield, degrading the visual, like the light that is impending on the photoreceptor, causing vision loss. Other important thing, we know that in the fovea, the Mueller cells are straight. And so what are these what are these things that are happening like in the fovea, in the epiretinal membrane, on in vitro macular traction, for example? So you see these beautiful horizontal lines because all the cells there are perfectly aligned. When these cells are not aligned, so they are pulled up by traction, you lose that reflectivity. And so you start seeing something called the cotton ball sign, which is this one. If the traction goes over and the Mueller cell is pulling the photoreceptor up, you start to see a foveolar detachment. And with chronicity, that foveolar detachment is filling up with vitelliform material. And if the traction continues, that vitelliform material will break the barrier of the external limiting membrane and spread throughout the outer nuclear layer. So this is what we found, and this is like actually is the same clinical spectrum. So when you see this thing on ERM is important because when you are at this stage, things may be irreversible, and you may have irreversible photoreceptor damage. So what's happened here? The rope is your Mueller cell, this is your photoreceptor, and this is the vitreous or the membrane. The vitreous is pulling and is detaching photoreceptors. If it continues pulling, that space is filled with vitelliform material. And if it continues pulling, that vitelliform material will then spread throughout the outer nuclear layer. Lamellar holes, very briefly, is very important as well because resolution of the OCT is also important because when the resolution was very low, we couldn't differentiate between different types of lamellar holes. And when the resolution improved, we were able actually to distinguish between these two clinical entities that we at the beginning named tractional and degenerative lamellar macular hole. So by knowing the anatomy, you know that these are like bridges of tissue and the tissue is just displaced. And here you see tissue is missing, and this is the key difference between one and the other. So displacement in tractional and tissue missing in the degenerative hole. And to remember, we decided to call them top hat and mustache, but I mean, this is just for you to remember them. Now, actually, the definition changed, and we included the tractional lamellar macular hole in the epiretinal membrane spectrum. So you should treat that type of hole like an epiretinal membrane. And this is what's happening when you exert traction on the Mueller cell in the center and the parafovea. In the parafovea, they can deform, they can comply for the traction, so the photoreceptors there are never stressed. Okay, very briefly, in full thickness hole, also new things that we discovered with OCT. Just look at the border of this hole. How you know the health of the photoreceptor at the border of the hole? Consider that the hole is like a small retinal detachment. So here, the borders are perfectly smooth, and here they are bumpy. Something is missing. Photoreceptors are missing there. So what's happening? Let me go just briefly through all this. So when a photoreceptor detaches, like in retinal detachment, it degrades, right? So it doesn't have oxygen or nutrients to be alive, so it suffers. And also, at the border of the hole, there are currents of vitreous that are continuously moving cells around, contributing to photoreceptor degradation. And histology tells us that at the border of the hole, photoreceptors are missing. Very important. So what's happening here? Photoreceptors are nicely there over the RPE, they're receiving oxygen and nutrients. When the hole forms, they detach, and it's like a retinal detachment. So they start to elongate. The outer segments are piling one over the other. And the degradation process starts, and then this falls over the RPE, and these are the granulation that you can see at the base of the hole. So when you see a hole like this at the left, everything is fine. You see a good outer nuclear layer, and the border is smooth. But when you see these missing areas, these black areas here, means that their photoreceptors are missing, and maybe so the surgical results are not so good. And that will be all. Thank you so much for listening.
Thank you, Andrea. Very nice. Questions or comments? Andrea, I have a question for you. Like you nicely highlighted now that we have peripheral OCT, how you're recognizing that there's traction on these atrophic, maybe even some percolated holes. We see this all the time now. So the question is, have you started to treat these now? Because obviously historically we wouldn't have, but now you have visualization and you see the traction.
Exactly. So that means that we can do a more detailed follow-up, so you can see actually if in months or weeks the hole got more traction, for example, and that can be an indication to treat. I started to treat them in myopic eyes because they are a higher risk of detachment, but we don't have yet enough evidence and enough patients and enough follow-up to support treating it in all cases. What I can say is that I'm convinced that they are due to traction, and they are not atrophic holes, as we used to call them.
Great. Oh, okay. One last question. Yep.
Does this apply to all atrophic holes? Because we know that at the bed of lattice degeneration, where there are no attractions, there are atrophic holes, and it seems that they don't increase the risk of these lattice to develop for RRD.
So we in all around non-operculated holes that we saw within the vitreous base, there was traction. So traction that you can see just with OCT. You cannot see with the slit lamp. You need an OCT to go through it, and you will see the vitreous pulling tangentially over the hole. There are other holes which are round, but with the operculum that you can see posteriorly to the vitreous base, and they are due to PVD. And in those cases, there is no risk because all the vitreous is detached throughout the hole. And the operculum is just there is no traction over the retina. And you cannot treat, you should not treat those holes. But different are non-operculated holes within the vitreous base.
No, I'm not talking about operculated holes, as you said. No, with no operculum. You think that all these, what we label atrophic holes without, they are with tangential traction?
I think that all of them, yes.
Okay, so thank you. So we're going to move on to our final presenter, who's David Saraf. David is joining us. He's going to give this presentation virtually from Los Angeles, but live with us. And it's new signature OCT signs that you should not miss. So David, we're looking forward to this presentation.
All right, thank you very much, Voss. Nice to see you and Andrea. Can you guys hear me okay?
Yes.
Yes. All right, wonderful. I just need to get my slides up. The atrophic holes, it looks like there may be tangential traction, and that's a wonderful observation, Andrea. But because the traction is encapsulated within the vitreous base, it may decrease the risk of detachment, as opposed to tears, especially flap tears, where there's release of the vitreous, and there's not that same encapsulation when the vitreous is separated from the posterior pole or from the equator, allowing a detachment to occur. So I think that's why we may see a decreased risk of detachment in these holes, even though there may be traction there.
I agree. I perfectly agree. You can see in many of them a pocket of liquefied vitreous just over the hole. You can see it with OCT. It is true that these holes, they create problems when the vitreous detach, because when the vitreous detach, the equilibrium is somehow changed, and then you can get the fluid into even the the round non-operculated hole. But I agree with you that if they are within the vitreous base with a compact vitreous, the risk of detachment is low. I agree with you.
That's right.
All
All right, so I'm going.
I was going to
Go
say your
ahead.
slides are up, but they've already advanced a couple of slides, so you might need to go back. But
No, I move forward
Okay.
just to save some time. So we're going to move to some clinical relevant signs on OCT. We've talked a lot about the technology and the systems and the anatomy, and now we'll put a little bit more clinical context to OCT, and especially these findings that have been described in the last couple of years, the last few years, that may have impact when you're in clinic. And the first one we'll talk about is one that was just actually published, the angular sign of Henle fiber layer hyperreflectivity, that we refer to as ASH, and was recently published in the Progress of Retinal Eye Research by Priti Ramtahal and a bunch of us, Dr. Sada, Dr. Foyne, and myself, on that paper. And in this paper, Priti describes this pathoanatomical finding where you can see the actual Henle fiber layer highlighted. And normally we don't see that. Even with directional OCT, you don't actually see the radial configuration of the Henle fiber layer. And Andrea beautifully showed the direction of the Mueller cells in the Henle fiber layers, which are vertical in the central area and in the peripheral area, but have more of an angular or radial or right angle appearance in the parafoveal. And in certain inflammatory conditions and other conditions, retinal vascular conditions, you can actually elicit the pathoanatomy of the Henle fiber layer that we refer to as ASH. And here's some examples. Now we talk about etiology as being anterograde or retrograde. Anterograde means that the lesions are originating from the choroid or from some problem originating in the choroid. And one very common entity or disorder to consider when you see ASH is AMPI. And in the acute stage, AMPI often shows the angular sign of HFL hyperreflectivity, as you can see here, the classic placoid changes on the color fundus photography. And then OCTA, of course, is a very instrumental tool, a very essential one to elicit the interchoroidal ischemia that is the etiology of the placoid lesions in AMPI and persistent placoid and other placoid disorders. And as I mentioned, initially these acute placoid lesions start with ASH lesions where you can see the radial configuration of the Henle fiber layer. They resolve acutely and leave RPE changes as a legacy of these placoid lesions, but acutely you'll see ASH. Another anterograde disorder that causes ASH is laser-induced maculopathy. And this can be a very important finding to elicit because the history is often elusive and very difficult to obtain from the patient. And this patient had a history, a young pediatric patient with a history of handheld laser-induced maculopathy. These patients also get choroidal ischemia and can even get choroidal neovascularization, as you can see in the red circle there. And another case of ASH in a patient with laser-induced maculopathy, showing the characteristic Henle fiber layer lesions. This is a patient also with anterograde ASH. You can see the choroidal ruptures, and trauma acutely can be associated with ASH lesions on the OCT. So this can be a very important clue to the etiology. Another case of trauma in both the right and left eyes, showing the Henle fiber layer lesions or the ASH lesions. On color fundus photography, you can see the characteristic commotio or Berlin's edema. Retrograde etiologies of ASH are associated with AMN and retinal vascular obstruction, and these are presumably the result of impairment in the deep capillary plexus. So here's a patient with acute macular neuroretinopathy. You can see the ASH lesions and the associated photoreceptor disruption, hyperreflectivity on the near infrared, which is very characteristic and important in the diagnosis of AMN. It's very interesting that central retinal vein obstructions and central retinal artery obstructions can cause both PAM, and Rosa talked about PAM very nicely, and contiguous ASH lesions. So there's presumably impairment in the DCP that causes contiguous disruption of the Henle fiber layer, in this case of central retinal vein occlusion, and you can see the characteristic ASH lesions in CRVO. And if you look at your cases of CRVO, CRAO, it's not unusual to see these outer retinal changes of ASH in both CRVO and CRAO and associated contiguously with PAM because of DCP impairment. There are other causes of lesions that can track in the Henle fiber layer, including exudates like in macular stars and hypertensive retinopathy, and also Henle fiber layer hemorrhage, which we've chosen to use a different terminology because these are materials that are actually tracking in the Henle fiber layer. And here's a beautiful case of MacTel with Valsalva, and you can see the characteristic Henle fiber layer hemorrhage that we say is different, we've defined as different as ASH. And plume is another example of material, in this case RPE, tracking in the Henle fiber layer, as in retinal dystrophies and in AMD, it can be very common, and it's the result of disruption of the RPE because this is actual material tracking in the Henle fiber layer and it's not an actual pathanatomical disturbance of the Henle fiber layer itself, we've chosen to term these lesions differently. I want to move on to exudation, and this is a very common entity that many of you have encountered, ballot or bacillary layer detachment. Actually, Voss described this many years ago as atypical outer retinal fluid accumulation, and Bailey-Freund came up with this more sexy term, bacillary detachment. And this is just fluid in the outer retina at the level of the ELM. It's not quite subretinal fluid. It's in the outer layer compartment just below the ELM. And the initial diseases that it was associated with were VKH and AMPI. But now the list of entities that cause this has grown exponentially. And we can even see this commonly in patients with neovascular AMD with this outer retinal layer fluid. Pachychoroid disease is also a very important spectrum of diseases with many new members of this family, including pachychoroid pigment epitheliopathy, as you can see in this case, pachydrusen, which is a specific type of drusen associated with pachyvessels and pachychoroid. And now more recently, we've described this entity called pachyvitelliform maculopathy, in which we get vitelliform lesions specifically associated with pachychoroid. The thick choroid disrupts the RPE, disrupts photoreceptor turnover, and it's not unusual to see elderly patients with vitelliform lesions, the result of pachychoroid. So when you see an older patient come in with a vitelliform lesion, look at the choroid and consider pachyvitelliform maculopathy as the etiology. There's not always a sinister etiology such as paraneoplastic disease. The more common cause is pachychoroid, and because it's a sign of RPE impairment, RPE atrophy develops in about 50% of these cases. Andrea talked about macular holes, and we recently described this new OCT sign called the hyperreflective stress line, which can occur in 50% of macular holes prior to the development of the full thickness defect. And so this hyperreflective stress line or this cracked eggshell sign can be a sign, a predictor of the development of macular hole, and it relates to the fault in the fovea that is created by the centrifugal development of the fovea. And you can see this before the development of macular holes. You can also see it after macular hole surgery. Here it predates the full thickness macular hole in all three cases. Recently, we had the pleasure, Netta Abraham put these beautiful images together of this condition that was initially described by Dean Elliott called foveal herniation. And in this case, you can actually see that the fovea has, because of the centripetal contraction of the epiretinal membrane, has caused the fovea to herniate through the hole in the epiretinal membrane. And with three-dimensional OCT imaging, en-face imaging, you can beautifully appreciate this foveal herniation due to centripetal contraction of the ERM. I think that these can actually respond beautifully and recover beautifully with epiretinal membrane peel, despite the very impressive appearance and remarkable appearance. And I think that these cases of foveal herniation beautifully indicate the etiology of IFO, which Andrea has originally described and reviewed in his beautiful talk. Eiffel, which is this ectopic interfoveal layer, is probably the result of centripetal contraction of the ERM, pulling the inner and middle layers through the fovea and reassuming the normal fetal position. And you can see these ERMs that have progressed from grade 1 to grade 2 to grade 3 with ectopic interfoveal layers, probably the result of centripetal contraction of an ERM. Rosa talked briefly about PAM lesions and the perivenular fern-like appearance that they have with en face OCT. It's important to realize that PAM lesions can be the only sign of carotid artery obstruction, as in this case, where you see the PAM lesion and the characteristic string sign of carotid dissection. It can also be a marker of GCA. They can be a marker of an occult central retinal artery occlusion, but you may only see the PAM lesions. And so it's very important to consider GCA in an elderly patient with perivenular PAM. And PAM lesions, as Rosa mentioned, can have a legacy of thinning. We used to call these old PAM lesions, but now these lesions have been called ripples or retinal inner perivascular, retinal ischemic perivascular lesions. And these are essentially old PAM lesions, but they also can be an occult marker of systemic disease, specifically cardiac disease and atrial fibrillation. So when you see ripples or old PAM lesions, and there's not a local vascular occlusive cause, think about systemic causes such as diabetes, hypertension, and even atrial fibrillation. And the last thing we'll talk about are these very interesting lesions, also in the inner nuclear layer, actually more accurately probably in the inner plexiform layer, called benign lobular INL proliferations. And these are these hyperreflective tumor-like lesions that are seen on the OCTB scan and have this kind of spindle appearance on en face OCT, and they've been referred to as blip by Aaron Nagill and Christian Sanfilippo, and they're very probably rare, but really cool, probably benign phacomatoses-like lesions within the middle retina. And that's it. Here's just a summary of all the lesions we've described, and I hope that you'll identify these when you're in clinic, as they will be very diagnostically and even diagnostically helpful and even helpful with management. Thank you very much for your attention.
Thank you, Dave. Thank you, David. Phenomenal presentation, really a wealth of information there. Any comments or questions from our audience?
I have a question on the angular sign. So you distinguish, right, between when material is accumulating between the Henle fiber layer from when it's like an affection of the Henle fiber layer itself, right? So how do you explain, like, physiopathologically the affection of the, I mean, that hyperreflectivity that you see in the Henle fiber layer itself?
Yeah, that's an excellent question, Andrea, and hopefully with more time, we can figure that out. But I think it could just be that there may be swelling, maybe an increased diameter in the axonal fibers of the rods and cones, or perhaps of the Mueller cells. Maybe there's swelling of the Mueller cells that allows them to be identified beyond the threshold detection of the OCT. Is the simple answer to that question.
Thank you. Thank you.
And you can see it either as a result of choroidal diseases, choroidal ischemia as an AMPI and laser-induced maculopathy, or middle retinal ischemic diseases causing impairment of the DCP. So I think that that's really cool. And the Henle fiber layer essentially joins the DCP to the choroid. And so I think that's why you can see them in either direction.
Very, very interesting.
Any last questions? I guess we're out of time for our symposium, actually, or our course. So thank you all for joining the OCT course, and I hope you enjoyed, all of you, retina, we're almost at the close of the meeting, but thanks very much.
See you, everyone. Thank you.
Thank you.